Are just coming in, so we'll wait a minute for people to join. The participants' numbers are going up. Ben, are we okay?
Yes, Dr. Rios. I think we can go ahead and get started. We're also on Facebook Live.
Okay. So my name is Dr. Elena Rios. I'm with the National Hispanic Medical Association, President and CEO. I want to welcome everybody to our first of a series of All of Us research program, Fireside Chat. I hope we're all near a fire and we're having a fireside chat. We are very happy to be a partner, a national partner with the All of Us research program, which is part of the National Institutes of Health. We have an exciting lineup of speakers today to have a discussion about some of the major concepts that I will discuss right now. I'm just going to introduce the speakers very briefly. Dr. Randall Morgan is with us from the Cobb Institute, director of the Cobb Institute. Dr. Alicia Fernandez is with us from UC San Francisco. She is the director of the Latinx Center of Excellence there. And joining us in a little while will be Dr. Aida Giacello from Northwestern School of Medicine. So very happy to have our distinguished researchers to discuss some of their experience, especially with diversity in research, which is really our topic. Precision medicine is all about diversity. Go ahead, Ben. So this is the All of Us research program. Yep. So what is precision medicine? Precision medicine is an emerging approach for disease treatment and prevention that takes into account individual variability in lifestyle, in socioeconomics, in environment, and biology. It is a radical shift in how each of us can receive the best care possible based on our unique makeup. Next slide. These are examples of what precision medicine in real life is all about. It's about the right treatment for the right person. So, for example, when you go to get eyeglasses, if you're like me and being nearsighted, I have to wear them all the time. You want to have 20/20 vision, but you've got to have the right lenses. For those who have diabetes, we now have better technology to now have insulin pumps. For those who have problems, perhaps they've had a gunshot wound or they're pregnant and may need blood transfusions based on their blood type. And for those who are getting older or born with hearing defects, need hearing aids. Next slide. So the cost of imprecise medicine, if you think about if we don't have precision medicine, what happens with patients? Healthcare is often targeted to the average patient. We learn in medical school about the male, 60-kilogram male, right? White male, not the individual. Health problems can take years to unravel with significant trial and error. Now for providers, doctors, nurses, and researchers, there's not enough research to draw on for clinical evidence, especially in diverse populations. Medical records are scattered in different places, and there's not enough time for analysis, one patient at a time. The cost of imprecise medicine for researchers is that there's enormous time and costs spent building IT systems versus doing the research. There's siloed data resources and funding opportunities, challenges acquiring large sample sizes, and slow translation of data into knowledge. These are all of the issues that precision medicine is trying to correct. Next slide. So the All of Us research program was actually developed by the NIH. Here you have Dr. Francis Collins, the director, explaining that it is a historic longitudinal effort to gather data from 1 million or more people living in the United States. Anybody that's living, whether you're a citizen or not, to accelerate research and improve health. By taking into account individual differences in lifestyle, socioeconomics, environment, and biology, researchers will uncover paths toward delivering precision medicine or individualized prevention, treatment, and care for all of us. Next slide. So the mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care by nurturing relationships, by delivering the largest, richest biomedical data set ever that will be free to access, and to catalyze a robust ecosystem. Next slide. And these are the core values of all of us. Participation is open to all. And notice the vernacular here, participants instead of research subjects. Participants reflect the rich diversity of the United States. Participants are partners. Trust will be earned through transparency. Participants will have access to their information. Data will be accessed broadly for research purposes. Security and privacy will be of highest importance, and the program will be a catalyst for positive change in research. Next slide. And one of the most transformational approaches is about diversity. The NIH has made a concerted effort to have national partners from the Latino, Native American, Asian, African American, and other minority groups, urban, rural, large cities, small cities. And this is important so that we can have more people involved in this research database so that the future researchers don't have to create their own subjects. Next slide. So all of us is investing to level the playing field so that diverse researchers will have equal access. More users, starting small, growing over time, having a centralized system, and that is available to the public. And next slide. So this is the last slide. The All of Us logo is here. Joinallofus.org is the main website. We have the Twitter handle, All of Us Research, the hashtag Join All of Us, and of course it is at the nih.gov. So now we're going to have a chat with our distinguished guests, and let me introduce them one more time before we start asking them questions. Dr. Alicia Fernandez is a professor of medicine, director of the UCSF Latinx Center of Excellence at the University of California, San Francisco. Dr. Randall Morgan is the executive director of the W. Montague Cobb NMA Health Institute. And Aida Giacello is Dr. Aida Giacello is a research professor, Department of Preventive Medicine at the Feinberg School of Medicine, Northwestern University in Chicago. So I want to welcome all of you. We're going to get rid of the slides there. And, like I said, this is about precision medicine, but we're going to take the approach at really looking at diversity. And so let me ask, and what I'm going to do is ask a question, and I'll just go, let's have a roundtable approach. And Alicia, Randall, Aida, just go ahead and chime in. And I'm sorry, Monica Rodriguez is also on our screen from the All of Us program, All of Us research program in Chicago. And Monica, if you'd like to chime in too. So the first question is, why have members of the Hispanic community and other underrepresented groups been excluded from medical research in the past? Maybe just, from your own experience, and let me just say, you all have different experiences from different parts of the country. Maybe just talk about your own experience. Dr. Fernandez, what do you think? Why have we seen excluded minority groups?
I think there are many reasons for that, and they're historical. And I'll leave it for someone to discuss specifically the African American experience, which is so important for all of us to understand. But with respect to Latinos, which is the population that I work with most closely here in California, I think there's a sense that that Latinos don't bring important diversity, and partly that has to do with why is it important to collect a diverse experience. And there has been historically very little outreach to Latino populations, and very little outreach that is targeted in a way that is understandable, targeted that is bilingual or in Spanish. And I think that we have sort of failed to make the case within academic medicine that Latino diversity is important, both in biomedical research and in biomedical research that focuses not only narrowly on biology, but more broadly.
Mm-hmm.
Right. This is Aida, if I may jump in. Can everybody hear me? Yeah.
Yes.
First of all, most of the research in this country is done in medical institutions, and academic institution particularly, where there are few Latinos or other minority investigators. And as principal investigators, project director, co-PI, which make the decision who gets included when you propose a particular grant and you start working on your research design. Mm-hmm. As a result, mainstream researcher, non-minority, they don't really think about the contribution of diversity into a particular project. They find it more costly, because if they want to include Latino, that means that they need to validate instruments that they're using for questionnaires. They need to then translate them. They need to then figure out the outreach and and how to be able to reach out. Latinos have been viewed and other minority as hard to reach. So mainstream investigators who don't understand the culture, who never work with the community, have difficulty in understanding how can we be able to reach out and recruit and enroll, and then be able to follow up, because Latino, that's another many, barriers. The Latino are very highly mobile. They change their phone frequently. And so it becomes more costly to include racial and ethnic minority. But remember that the problem is not just vulnerable population. It's also people with disability that are excluded. Women as a group don't participate in the same level. People who are older tend to be excluded, or too young. So right. There's a number of groups that are also being equally impacted, including us Latino. Yes.
So let me just say, Aida, thank you you actually jumped into another question I was going to ask, but that's okay. Let me get back to the question of exclusion. And let me just say, you mentioned a lot of different groups, but the focus here is exclusion. So Randall, in your experience, and you might want to focus on the African Americans here, why do you think there has been exclusion for that particular group?
Well, I think that there's several reasons, but if we think about access to care, and with the large majority of African Americans, I would dare say that their access to care is not a smooth physician to provider relationship that has existed for years and years. It tends to be episodic treatment, a different provider each time they seek treatment, different place in which the treatment is given. And so therefore, there's no ability to develop a relationship, a trusted relationship with a provider. Mm-hmm. And therefore, it's unlikely that an individual in that situation would be included in a clinical trial unless they just happen to be at the right place at the right time for their particular condition. And certainly without the participation of African American clinical researchers and providers in clinical trials, which presently for FDA approved research is approximately 5.7%. It's highly unlikely that these individuals are going to encounter trusted sources that are already doing clinical trials that can offer them that opportunity. So that I think if it's not a situation where the cultural competency is important in whatever the institution happens to be, and that's been brought up already, if that's not a concern from the top, then it's highly unlikely that African Americans are going to participate in clinical trials in a large number.
So you all mentioned a little different issues. And I'm going to say that Alicia really focused on the language and Latinos in her experience in attracting them to research. Randall, you talked about the importance of access and not having a trusted person to bring the people into research. And Aida, you talked about a lot of different groups, disabilities, women, you know, and Latinos, cultural issues. So if you could focus in on what you just talked about, but now tell us, how does a young researcher break down those barriers? What is it that you can do as an individual researcher, or if you're a medical school, or if you're part of a clinical trial in a healthcare system? What can you bring up to the leadership? What can be changed? Just to try to knock down these barriers. How can you knock down barriers?
Well, this is Aida again. You have to, first of all, have a commitment to diversity. You have to truly believe of the need to be able to acknowledge the kinds of contribution the diverse population bring into in enhancing new discovery and research activity. Then you really have to develop partnership with the communities that you want to target. And that's one of the uniqueness of the All of Us program, that we have been able to develop, advisory council, nationwide, kinds of boards that include participants who are actually enrolled in the study. So the partnership with the community is critical. And then bringing the research to where the people are, which is some of the things that the All of Us does through the mobile clinic. So instead of expecting people to come to a clinic, to a hospital and be enrolled, you go to the community health fairs, you go to the school's activity, you go to diverse setting where you're going to find the individuals that you are interested in enrolling.
Okay, let me move on to Dr. Fernandez. You mentioned some issues. How would you break down those barriers? Again, how have you done it? But how would you, counsel others?
Yes, I completely agree with what was just said, that it starts with a commitment to diversity. And here we have people trying to help with our CTSA, with trying to help on for all research projects. And that takes many forms. One is to make sure that there is a lay description of the trial in the target languages, be it Spanish or also, for example, here in San Francisco, in Chinese. It's very important. So that's the sort of thing that is not that expensive to do, and which an academic medical institution can readily do. But the second thing is that at the end of the day, someone has to speak with the patients, and someone has to enroll them and answer their questions and so on. And so this really is a commitment to diversification of the workforce, and not only diversification of the faculty workforce, but diversification of clinical research assistants. And that is where we are trying here to build partnerships with some of the local universities, San Francisco State and other local universities, as these are good careers for folks. If they can be trained to function as, to work as clinical research assistants, as a diverse workforce, a bilingual workforce, a culturally competent workforce, and training and making a commitment to training and creating sort of on-ramps into the academic medical center. That then lowers a barrier that Aida was talking about. Oh, how am I going to include such and such a group? I would have to hire new research assistants. I would have to get my materials translated. I would have to do all of these things. And by making that more widely available within the institution, it lowers the bar for researchers. Now, at the end of the day, I also think that there's more that NIH can do. So for example, NIH quite rightly has, as part of the reporting mechanism on all applications, it asks whether minorities are included in the trials, and also asks about breakdown by gender. And that is important. One of the things that I think NIH needs to consider is whether for certain subjects, it is important to ask whether or not people who speak another language are included. And for some things, it's not important, but for others it is. For example, if you're doing any form of diabetes care in California, whether it's analyzing a new treatment or a new way of taking care of people, Latinos constitute almost 40% of the population. The majority of people with diabetes are Latinos, and half of those have limited English proficiency. So to me, it doesn't make sense that NIH would elect to fund a study where the researchers are not explicitly addressing those issues, those types of issues. But I think that, and I'll stop here, but I think that Aida's completely correct. It requires a comprehensive approach, starting from the very top of the academic medical scene.
Randall? Well, thank you, Alicia.
All right.
Randall?
I agree with all of the recommendations that have been made. However, this is such a large problem, and with problems come opportunities. And so I see that each and every center that is participating in research can be rather introspective in developing a methodology that will work for that particular center. And so I think the first thing that needs to be done is that someone should be identified with the same cultural background who has participated in a trial in the past, to be able to discuss that participation with the potential enrollee. And that's irrespective of what form, or rather what group that person would represent with regard to diversity. So I'm speaking across the board, not just certainly for African Americans, but even sometimes demographic diversity. If someone knows someone who has participated in a clinical trial and particularly benefited from it, I think that's an immense help in terms of trying to break barriers. We've talked about anticipating language barriers that might exist and making sure that there are the proper support mechanisms that are necessary. I practice now in Florida after over 30 years practice in Indiana, and I'm still not very good with my Spanish, but I'm excellent with getting a translator who can help me and make sure that the patients understand exactly what we're talking about. And I think if those patients feel that the physician wants to know everything about them and understand what they're saying, they will trust them if that same physician is encouraging them to participate in a clinical trial, even though they don't speak their primary language. I think that we have to provide intense cultural competence education for all those faculty providers and others who participate in clinical trials. And obviously, this is a cyclical situation. So every time a new group of trainees comes in, every time a new group of employees comes in, there has to be a purposeful rehearsal of this cultural competence evaluation and education. And finally, the organization itself should create an achievement goal in terms of diversity in clinical trials. So that when the clinical trial is begun, before it started, I think there should be some analysis of what the goals and objectives are, not only in terms of the outcome of the clinical trial, but in terms of the cohort and the diversity of the cohort. So I think those things could be done in any academic center, large or small, and even in some of the larger private practice organizations that do clinical trials.
So let me ask something that I think Randall just brought up that follows with the commitment in the leadership of an institution to do research with diverse populations, and that is you have to have some type of cultural competence training. Can you comment on, I think it's important for the audience to understand that there's probably a wide variety of trainings all over the place, but can you comment on what you do at your institution, and maybe there's some lessons learned that you've learned along the way from a variety of different, I'm going to say, activities that you've been involved with related to research? How would you say that a new group of researchers need to understand how to take care of the limited English proficient Hispanic in California with diabetes, or the Puerto Rican population, Aida, that I know you've done a lot of research in Puerto Rico, and Randall, the people in Florida that you're taking care of? What would you say are some of the top ways to build cultural competence before one gets involved in talking to patients about research?
Well, this is,
Well, I'll just mention one, and then I know my colleagues have many more solutions. But one simple way, because I'm in private practice right now, I'm not practicing in an institution. And so I would say that would be time. And by that, I mean, you have to have a different schedule for working with patients in which you're going to, which you feel there's a cultural barrier of any sort. And they can't just be in the same schedule where you're trying to run through and run out and not really listen and be able to provide as an individual that capable, culturally sensitive care.
Okay.
And so that's just one point I would make, and I will leave it to the others who are working in centers to maybe give a better, or rather more complete answer to that.
Dr. Fernandez?
Yes, I agree. And let me say a few things. I'm not sure that, I'm never against training the PIs, but I don't know of data showing that training the PIs helps a lot. The approach that we're taking here is we are, for example, let me give a concrete example. As you know, with COVID-19, there is many people are trying to do research as quickly and as efficiently as possible, both on the biomedical side, on the treatment side, on the vaccine side, and on the public health side. And so one of the things that we created here at the highest levels of the university was a CAB. A CAB is a community advisory board. And we have a CAB that represents multiple different communities within the city. And they are now we are now trying to push all of our COVID studies through the CAB. Now, it is more voluntary than required, but it is heavily encouraged. And the reason for this is that we don't want, many of us are working in this space, we don't want other investigators to go in, do something with the community that we think will leave a bad taste in community members' mouth and make it difficult for the rest of us to do research. Consequently, we're really encouraging everyone who wants to recruit community members to talk with the CAB. And I think that is a very useful approach, and one that is not that difficult for large medical centers to do. It is certainly the approach that, for example, has been encouraged by PCORI for a very long time, and I should note that I'm on their board of governors as a conflict of interest, in which we do have advisory members to give direct patient stakeholders give direct advice as to recruitment and so on. And I think that we need to have that approach institutionalized at all academic medical centers. There's no reason why an academic medical center can't have many different forms of community advisory boards and so on. Finally, well, actually, let me stop there and please.
Yeah. So Dr. Giacello, again, just maybe one pearl of wisdom
Well, you mentioned, yes, you mentioned the whole issue of cultural competency.
Yeah, yeah.
And when we talk about cultural competency, we're talking about having the skills of using community knowledge and culture and other factors that has to do with the characteristic of the community into a process where you could be able to approach diverse racial and ethnic group, or sexual orientation group, whatever, into getting the kinds of objective and in enrollment into a particular research study. So in cultural competency, it is critical for the investigator to know what are the community that they're being studied in terms of their socioeconomic status, immigration status, language use. Now all Latinos speak, Spanish, so we also have to have different approach for those Latinos who are primarily English speaking, US born, etc. And so you need to really custom make your approaches once you have developed and taken the time to develop your own cultural knowledge about those attitudes and explore your own biases that we may have in the process of socialization to a diverse population that we had to deal with. And so Dr. Fernandez mentioned about the institution. Yeah, the institution has to become cultural competency through the commitment of the leadership and allocating funding to recruit minority investigator faculty and make sure that there is structures on health equity in different universities and where the research are being conducted. So we could have an infrastructure that is aimed at really enhancing that competency. But at the same time, at the individual level, when I approach individuals, it takes the personal touch. It's having a smile when you talk to them, eye to eye, contact, presenting the information in a simplistic way. Because sometimes we use too much jargon in research, and the community with low levels of literacy perhaps may not be able to understand. Be prepared with the kinds of questions that people may ask us in terms of the safety of the data, in terms of many other elements that has to do with the research protocol, that we need to really make sure that there's transparency, that we are telling the people exactly what is going to happen, and to be able to provide some of the benefit that they may be able to get in participating in a given study.
So let me take off on that. Another question that we have here is, what is the advantage to research? And in this case, the All of Us research program. What's the advantage in having diverse research subjects or participants? Randall, do you want to comment on that?
Well, I think it is essential that there be diversity in order to assure that each ethnic group, gender, geographical location, representative, and the like have been a part of a specific research program or product development when a new product is approved by FDA. So purposefully, there are all of those boxes checked through the process of the trial. And if there appears to be a deviation in terms of that optimal representation, then perhaps that should be a barrier to that pharmaceutical reaching FDA for approval. I think that there's a savings to the pharmaceutical R&D process by ensuring that there are accessible, diverse trials, and that they can be conducted, hopefully, using this All of Us cohort. I've always felt that this could be an advantage, so there needed to be fewer offshore trials and the like, and more rapid trials. And I know we'll get to that discussion in a bit, but COVID-19 has shown that when there's an all-out effort to try to make a change in either vaccination or treatment, it would be wonderful to have 1 million individuals in a cohort to work with in real time in terms of developing new treatments. So those would be two areas that I would think are very, very important and why we need to have diverse representation in the research program.
Dr. Fernandez, any other comment on just the general question, why do we need more diversity within the participants? Why is this so transformative for all of us to actually be headed in this direction?
Right. I think Dr. Morgan gave a great example, and that is COVID-19. If we want to study the impact of the pandemic, for example, on people's mental health, which I believe is one of the proposals in all of us. Well, we all live in different communities. We live in different ways. We have different socioeconomic status, different degrees of different worries. We live in different multi-generational housing or not, have children or not. It's super important to have a broad representation of the reality of the United States in order to answer a question like that. And that's a very straightforward example.
Yeah. Dr. Giacello, do you have anything else to add on?
Well, you know, most of the people who participate in research, from my perspective, they really want to give back. They really want to be available to be part of the solutions. Within the context of all of us, what we're trying to do specifically is to be able to develop it for the near future, hopefully the near future, custom-made, individualized intervention. So we could be able to find out what are the best procedures to prevent certain condition, or to diagnostic, or to care in terms of the treatment. And how can we be able to engage in a process that maybe immediately may not have a direct benefit to the participant of the study, but could have tremendous amount of benefit to their children and grandchildren and future generation. So the benefit has to be laid out very clearly. Maybe there may not be direct benefit, although there's stipends involved in many of the clinical research study, including all of us. But the people have to understand that it goes beyond that we're moving in an era where we are moving into precision medicine, making your medical care precise, individualized. And that for this effort, there has to be the participation of all of us, of all diverse groups, to be able to come up with those kinds of precision medicine strategy that would improve overall health. And another group of people are interested because they have certain illness, where multiple sclerosis or whatever the condition for which we know the difficulty in the early diagnostic and treatment of many of those conditions. And therefore, people want to make sure that other individuals who may have similar experiences as they will be able to have then the hope of getting many treatments that would be more effective than the one that is being provided. Right now, medical care, as you mentioned in wonderful presentation, is basically, using average studies that have been done on diabetes or whatever the condition, and then treat people based on those kinds of results. With all of us, with 1 million people in a database for different kinds of research, we could be able to know exactly how to custom make certain medical care for certain individuals that have common characteristics.
So thank you all for answering that. We have a couple of questions right now in the chat. I'm gonna ask one person to answer one and one person to answer the other, so we can make sure and answer these questions. One is, can you talk about the importance of using community health workers? And I leave it up to, can one person answer that?
I can answer that if you like. I completely agree with the idea of using community health workers to recruit and to promote the idea of participation in research. And I think that is something that we're experimenting with here, and it is really helpful. I don't know that I don't believe we have any data yet on that, but working through community-based organizations that have community health workers, it works really well in terms of being able to recruit a more diverse sample. My understanding is that that's how all of us has recruited such a diverse sample of participants.
And I think the trust factor is a big issue there that was mentioned by Aida and everybody earlier.
Right, and I want to add, if I may, very quickly, it's the community health worker or people from the community that live in the target community that we're trying to recruit. So the importance here is to make sure that we have, as part of the research team, in whatever capacity for recruitment, retention, and other kinds of role, individuals that represent the communities in question. They knows who are the gatekeeper, we call it, the leaders. So yes, they could be called community health workers, but it's people that are knowledgeable, capable, have a wonderful ability to connect with the average person in their neighborhood and be able to explain them the difficulty of research design and purpose of a research study.
Okay, so let me ask a question for Randall. Randall, this is a young medical student who said, and it's a Latina, a woman, medical student, who says in her question that she's about to be part of a research team in a month, and they're going to enroll patients, and nobody on the research team is diverse. I'll just say that. I don't know what she meant by that. Maybe there's no Hispanics, no African Americans. And in a month, she'd like to know what could she do to change the focus of the research team, and how could she bring up and I know, in medicine, we have this hierarchy of medicine. It's kind of hard for a medical student to change the faculty's decisions, especially when they've already written a proposal. But what would you say to a young medical student who's on our line on how to help educate in a way that a medical student can about the importance of their community to be part of the research project?
Sure. Well, I think that's a wonderful question. And first, let's state the reality. And the reality is that research team represents about 99% of the research teams that exist in the United States these days. And that's why we're discussing this problem, where there is not diverse representation in the research team, and certainly not at the leadership level of the research team. So I think trying in some way to influence whoever the leader of that team is important. But I never minimize the impact of medical students, because they're smart and because they can ask questions that will absolutely penetrate the entire issue. And I think maybe a question about diversity and what the goals of the trial might be, and considering the percentages of clinical trials that have been done that have not represented underrepresented minorities very well at all, neither African American, Hispanic, or others. The student should properly query, well, are we expecting that we're going to have a certain representation in this trial? And if not, how can we make that happen? So that I would probably approach it that way. But I think staying involved and being a part of the whole process is the first thing that the medical student should do, because that observation is totally accurate.
Yeah, I think that all of you represent a long careers of having lots of, I'll say, setbacks, but you have moved forward despite either personality issues or people that just don't see things the way you do or we do. And the more diverse people in research, the better, and eventually things will change. I do think with COVID-19, and I'll bring this up too, because Alicia brought it up, but we have, or Randall brought it up, we have a great opportunity right now because the whole country has realized the social determinants of health are real. There are underserved communities where we don't have enough healthcare services. We don't have enough diverse doctors and nurses and community health workers. We don't have enough food to have healthy lifestyles. So we have all this diabetes and heart disease and cancers in our communities. And that's why we need to have more researchers who come from our communities who can bring the people along into the research. And it's just a cycle that we have to build up into this research. I'm going to say the All of Us research program is dedicated to trying to have more diversity. And I think that we have an opportunity with COVID-19 because there is such a recognition that we should change the way we have developed our healthcare system, to have a little bit more on the prevention side and the public health side than ever before, because it's needed right now, and probably for the next year until we have the vaccines and herd immunity. You know, we're not going to have it with a lot of people probably until the middle of next year. So given all of that, I want to get back into the questions that we have proposed here. Was what else can the All of Us research program do to help diversity? To have increased diversity in research? From whatever angle, what do you think could be an activity for the All of Us research program? And let me just say, why don't we talk about Latinos? What is it that will bring more Hispanics into the All of Us research program?
Well, this is Aida. We discussed some of that. I mentioned some of that about the fact of going where the community's at, informing the community. So there has to be some kind of health communication campaign so people know that right now there's a recruitment phase and the importance of participation in those kinds of study. Going to where the community's at, making sure that you have people from the community, where there's community health workers or not, that they look like the community that we want to recruit, and make sure that our efforts and approaches are culturally and linguistic appropriate to be able to engage those individuals that we desperately need to recruit. The All of Us has done a very good job. I mean, at least in the Illinois, through the Illinois Precision Medicine Consortium, I think we have about, we are second or third in the ranking or recruiting racial and ethnic minority. And so it is a matter of taking the time for the detailed planning and be able to get the individuals that could be able to help us in those efforts through the proper training and capacity building so they could be able to be most effective in those efforts.
Okay, and Dr. Giacello, we lost your video. You must have turned it off. There you go.
Okay, what happened was
back.
that I ran out of battery. I apologize.
I agree.
I'm just going to throw in a number here. One of the questions on the chat was about the, what's the goal for diversity here that we're really talking about? The All of Us program has a goal to have 50% of their participants come from racial and ethnic minority groups, and that is phenomenal. And so, so I know that what we're doing today and reaching out to the audience here to encourage them to have more diversity at the top of their objectives when they do research. And Dr. Fernandez, you were going to say something on?
I just wanted to add to, I completely agree with what Aida said, and I just want to highlight two things. One is to partner with community-based organizations. That's really the trusted intermediary, so that in addition to having clinical research assistants and a more diverse workforce within academia, having long-standing established partners with community-based organizations that can serve as trusted intermediaries, I think is crucial. And the other one is more of a question I have, and perhaps Dr. Morgan could address it, but I believe that partnering with private physicians is also important. And the reason for that is that most people will enter research through their physician. And their physician has to at one point say, I think this is a good idea. I think that you might get something out of it, or you could contribute in a good way. And what do you think? And I know this trial, and this is a good trial. And I wonder what you think about the outreach. I don't know how much outreach All of Us has been able to do to individual physicians. And I wonder, Dr. Morgan, what you think of that idea, and if that's realistic for a busy physician in private practice.
Mm-hmm.
Well, thank you for asking that question, because there are a number of partners in this quest to increase the participation in All of Us. And I think our organizations, the National Hispanic Medical Association and the Cobb Institute, NMA, really represent the providers in terms of how they get involved. And so specifically for the past 3 years with the Cobb Institute, we have really focused on providers. We focused on education. We focused upon getting providers buy-in, even in terms of some of the collateral materials that were used early on to educate people about the All of Us program. And we've gone through the security aspects of the database. We've gone through the ethics. We've gone through a lot of questions that providers have brought up. And we think we have answered a lot of those questions. We have gotten back to those individuals many times through pilot studies, focus groups, and the like. And we feel now that we have providers who have not only joined, which I think is the first thing that providers need to do, but the second is to be really influential with their patients in terms of getting them interested, educating them, taking the time, and having them be a part. The last thing I would say is that the other aspect that we have tried to begin is encouraging providers to look at the All of Us cohort as a research opportunity, and particularly for community researchers and not just academic center researchers. Because if these physicians that do clinical trials and have interest in clinical trials actually promote the program, then it will be beneficial as well. And it will be beneficial for the clinician as well in terms of his or her research.
Yeah, I just wanted to mention something about the importance of the National Hispanic Medical Association as a national partner, along with the NMA and the Native American doctors, the Asian doctors. We've all been working together for a few years now as an alliance. We call ourselves the Alliance for Multicultural Physicians. And I think as an alliance, and it's just a network, we're not trying to create another organization. But as an alliance, we have met with FDA, we have met with OMH. In fact, the Office of Minority Health has agreed to bring all the offices of minority health together to meet with us, just so that we can find out more how we can be of use, But in terms of clinical trials and research, how would you suggest we work with the institutions, or that we work with, research trials? Do you think that the major way we can help is recruitment of individual doctors within our ranks? Is it mentoring, finding senior researchers with junior researchers? What is it that you think we could do, reaching nationally and reaching through our ranks? And I'm talking about younger researchers, residents, even medical students who have an interest in research. Any suggestions?
Well, this is Aida. I think that you need to develop a network of clinical trial physicians at the community-based organization. So they could be able to be ready to go, so to speak, after they have been engaged in training and become knowledgeable of the different potential clinical trial and their potential roles and responsibility in this trial in recruiting Latino. What has happened traditionally is that most of the time investigators from academic institution and other research entity, including pharmaceutical, they want to recruit patients from the different physician clinic, and without compensation of those physicians for facilitating the linkages. And in top of that, some of the physician has the fear that they may lose patients if they are recruited into a university or another setting of clinical research. And so those kinds of fear at the community level, I'm a healthcare provider, we need to really clean it up, make sure that they are not taking advantage, that sometimes may happen. But I think building a clinical trial network of those young physicians together with others that are in the community, in storefront clinic or whatever you want to call it, that may be part of that whole effort, getting a pharmaceutical to be able to provide funding for the initial effort while you start then applying for NIH grant to be able to be part. And then collaborate with other university. University right now needs the Latino recruitment. So collaborate with those large studies that are being constantly proposed and for which they also want partners that represent diversity that could bring that constituency on board. And all of us have done an excellent job, as Dr. Morgan has said, in bridging those kind of partnership with nurses, the Hispanic Nurses Association, and many others.
Right. Alicia, any comment on that?
I think I want to give a shout out to what National Hispanic Medical Association is already doing, and to continue to do that. I think sometimes it isn't obvious to everyone, but when you sponsor conferences, as you have your annual conference, or your wonderful training programs, and I am a product of the young faculty training product of yours, that helps people, not researchers and non-researchers within academic medical centers, get ahead. And it helps the leadership skills that you impart are part of what will eventually transform all of this. So thank you for what you're already doing. In terms of what's new, what I would encourage you to do is ask academic medical centers to create community advisory boards, CABs. This is easy. It is cheap. It will pay dividends by having people, by strengthening the connections to community-based organizations. And this is something that all academic medical schools can do very rapidly and very easily. We do pay a small stipend for people to come from the CBO to the meetings, because I agree with Aida that people should be compensated for their time, but this is not very much. And again, having then researchers get used to working with the CABs, having the CABs get used to advising different types of researchers will pay dividends. And I think it's a very promising strategy.
I want to ask you, Dr. Fernandez, we have a question on the script here, not on the script, but on the chat about the CAB concept. And I'm wondering if we could get maybe a paragraph, or if you have some kind of guidance that we could send out to people afterwards. This was
I'll get that. I don't. I will.
A New York Medical School, a researcher there would like to be able to start the same kind of concept. Another question that came, and this is from one of our leaders, Russell Bennett, wondering if you would consider, and this is for all of us personnel too, would you consider recruiting people from Mexico or from other countries? And again, we're talking about the dire need and the critical need for having diversity. I don't know, Claire or Monica, is there an answer to that? It's my understanding that this was just the United States, people residing in the United States, but is there a way to increase Hispanic diversity from Latin America?
It's not part of the plans right now. Like you said, Dr. Rio, it is recruiting people that live in the United States. So maybe that could be a proposed project for the future, but right now we are pretty busy with what we have in recruiting 1 million people within the United States.
That being said, I will add that currently the only restriction is that someone resides in the United States, but if you do not have to be a citizen. So we do welcome, immigrants who are currently living in the United States without citizenship, and we encourage it because it is representative of the population that's currently across the nation.
I also think that it would, I would take that suggestion. I'm sure it comes from the best possible place, but really, all of us has already done a good job with diversity. It needs to continue to do even more. It would be really shocking to me if in a country with 300 million more people, we can't recruit 1 million people, diverse people from within the country. And if you go outside of the country, you may be losing some of the socioeconomic diversity that is so important to include within all of us.
Okay, well, you know what? I know there's a few more questions. We're not going to be able to get to them. I want to thank our participants, Dr. Alicia Fernandez from UC San Francisco, Dr. Randall Morgan, and Dr. Aida Giacello. And I also, you know, we at the National Hispanic Medical Association, we are a national partner of the All of Us research program, and we decided that we would hold a series of fireside chats about different topics in research. And I'm putting up this slide here so you can see that today was about precision medicine and talking about how unique minorities are, especially Latinos and African Americans, to increase precision medicine. Next in September 24th, we are going to talk about enrollment and how to enroll more diverse participants. In session number 3 in December, we're going to talk about seniors and the special role for seniors within research. And in January, we will talk more about, I guess, other aspects of research best practices in our research institutions. And also, I think it is important, like Randall mentioned, to think about research among practicing physicians. And with the Cobb Institute, I think we need to think about how we can work together. And then our last session in May will be on women and women's health research. So let me thank Ben and all of the staff, all of the people on the phone who joined us today on the I guess on the webinar on Zoom, and also our staff here from the All of Us research program at NIH. Thank you all very much. And
Thank you for having us.
Have a great
Thank you. Thank you. It was a pleasure.
Thank you.
Thank you. Thank you so much. Thank you so much.
Sure. Aida.
Bye.